Okay, this is my audience. And then, okay, good afternoon, Debbie and Sarah. My topic today that I will present is why did the FDA limit the use of simvastatin 80 milligrams? First, we'll start with the patient case. It was a 70-year-old female. She had a history of diabetes, hypertension, smoking, chronic obstructive pulmonary disease that was mild, and mild angina. Now, I put a little star there because I adapted this case to add another twist to the case to emphasize the drug interaction that's involved here. Her presenting complaints were only diffuse myalgia and mainly the upper and lower extremities. Her current medications were simvastatin 40 milligrams. She had been on it for a year. Valsartan 40 milligrams a day, metformin 850 milligrams a day, and I added the verapamil with angina 120 milligrams a day. Her labs that they tested for when she first came in, there were no signs of renal damage. Her thyroid was normal, and all the cardiac causes of the muscle pain were ruled out. And further muscle breakdown reasons were also ruled out. The second and third, the CK-MB fraction and the troponin t-test are measures of acute myocardial infarction, so she was not in that. They were testing her liver, her kidney. So the question is which medication is causing her rhabdomyolysis? And to think about, we'll think about those questions, and which alternative statins could this patient use? And the objectives for this presentation, at the end of this presentation, you pharmacists will explain the FDA limits on simvastatin's 80 milligram dose in adults with dyslipidemia, describe who is most at risk for simvastatin-induced myopathy, and explain the steps you as a pharmacist would take to prevent the simvastatin myopathy. Further, you would recall the lab values and the genotype markers for simvastatin-induced myopathy, and you would select clinical and lab results indicating the presence of simvastatin myopathy to motivate the prescriber to change the unsafe simvastatin dose to lower it, or to change to a lower myopathy risk statin. Definition of the rhabdomyolysis was the acute increase in the creatine kinase serum concentration to 5 times the upper normal limit, and also the exclusion of the myocardial infarction with the creatine kinase NB fraction is less than 5%. So in this study, they did rule that out. The early presentation would be muscle pain, tenderness or weakness, and the darker red color urine. In the literature, I've seen Coca-Cola look, and unexplained fatigue. The immediate consequences is hyperkalemia. So I got this off the internet with the peak T waves. The hypocalcemia from the binding and the damage of the muscle protein. What I've read is that it doesn't show up so much on the EKG. The major complications are the well-known acute renal failure, you get the intraluminal myoglobin cast formation, the heme protein nephrotoxicity, the renal vasoconstriction, and the visible myoglobinuria, the T-cola colored urine at the levels of more than 250 nanograms per milliliter. And then cardiac rhythm abnormalities and compartment Sjogren's syndrome. Overall, you can get myopathy from for other reasons other than taking statins, and that rate is 11 per 100,000 person years. And the rhabdomyolysis depends on the statin, and these are the primary offenders, the lovastatin, simvastatin, and atorvastatin, just the 4.2. So it doesn't comprise all of the rhabdomyolysis. It also depends on the metabolism of the statins. If you take it with another cytochrome P450-3A4 enzyme, that will block the metabolism of the drug. So we've got the lovastatin, simvastatin, and atorvastatin. 2C9 is rosuvastatin and fluvastatin, and the hepatic and renal is pravastatin. So you will see later that those that are metabolized by the 2C9 or the hepatic and renal metabolism, those do not have as much of a problem as the myopathy, because it's not blocked by other 3A4 blockers. And it also depends how lipophilic or hydrophilic they are, and it turns out that the more lipophilic, the lovastatin, simvastatin, and atorvastatin are more lipophilic. They get into the muscle easier, and that's why they cause the adverse effects. And the less lipophilic, or they call it relatively hydrophilic, are the pravastatin, rosuvastatin, and fluvastatin. And a few stats and facts on the statin myopathy. The creatinine kinase levels in the myopathy, just myalgia, you don't see creatine kinase elevation. But incipient myopathy, where they're on their way to myositis, you can see muscular symptoms or no muscular symptoms, but you would see 3 times the upper limit of normal of the creatine kinase. And the myositis, which is the next step worse, is the muscular symptoms with the elevation of the creatine kinase. Rhabdomyolysis would be the creatine kinase 10 times the upper limit of normal, and serum creatine elevation, and occasional presence of brown urine and urinary myoglobin. So it progresses from myositis to rhabdomyolysis. So who is more at risk? So I Googled for an aged Oriental or Asian descent lady, so that you have that picture in your mind. Women more than men. Women have less muscle mass to absorb the hit. Of Asian descent, they found that they had a higher incidence, over 65 or over, kidney impairment, liver dysfunction to more than 3 times the upper limit of normal, and or uncontrolled hypothyroidism. And then they found in this study that on the chromosome 12, this genotype, SLC01B1, is a variant, and those are the people who are getting the myopathy. So more, as I refer to as the drug interactions, the 3A4 blockers or inhibitors lead to the raised simvastatin levels. And in the article, they were saying the risk of myopathy, including rhabdomyolysis, is dose-related. So with the drug interaction, you're seeing a higher effective dose in the blood. And the study in question was called the SEARCH study. They titled it The Study of the Effectiveness of Additional Reductions in Cholesterol and Homocysteine Collaborative Group. It appeared in Lancet. Was in November 25th. And the results of the study were picked up by the FDA. And what they did was it was 7-year multi-center, double-blind, randomized, the gold standard, Roughly 12,000 myocardial infarction survivors, men and women between 18 and 80, and those who had a history of a previous myocardial infarction. And what they were trying to do is basically balance what is the optimum dose with the least amount of side effects with the myopathy. So they were getting the results. They were using as a placebo the folic acid 2 milligrams and the B12 1 milligram. And there they compared the 80 milligram to the 20 to see if there was any, if they could get the same efficacy without the side effects. And these were patients with high-risk cardiovascular events, and they were trying to demonstrate at least as much decrease in cholesterol as the 80 milligram as they would see in the 20. So they compared two groups, the intensive, which is the 80 milligrams, versus the 20 milligram, and then they used the supplements, the folic acid and the B12, as a placebo. They had some exclusions. They included only people who had the need for the statin and were currently using it, and they had no need for the folic acid like they were, and they didn't have the gene that required an increased amount of folic acid. And their total cholesterol had to be within these limits, more than 3.5 millimoles per liter if they were on statin, and 4.5 millimoles per liter if not on a statin. And there were no other contraindications to the study treatments. The exclusions, they wanted to make sure people were going to be compliant. As it turns out, they did have an issue with compliance. And they did the run-in on 20 milligrams a day and for 18 weeks. And they made sure that the patients were not taking any other statin other than simvastatin. And the outcomes they were looking for were coronary death, myocardial infarction, stroke, arterial revascularization, and then they wanted to see actually if the placebo did anything. And so what they figured that the only difference between the 80 and the 20 milligram would be only a 0.5 mole per liter difference in the lowering of the cholesterol. And that might reduce the major coronary event by 10 to 15%, which is pretty decent. As far as the dropouts were concerned, they tried to follow up with the patient or their physician, and they took alanine transferate concentrations and creatine kinase. And they did conclude that the lowering, well, they set out to say lowering the LDL cholesterol does lower the major cardiovascular events. So we know that. And the intensive dose, 80 milligrams, reduces the major vascular events further than standard lowering. So they looked at the risk of the myopathy with the doses. So for 20 to 40 milligrams, they had a low amount, just 1 per 10,000 patients per year. But with the 80, it went 10 times with the myopathy. So then you've got to start weighing 20, 40, 80. What are you going to do? So, and that tends to occur during the first year of treatment, and it occurs mostly with the offending genotype SLC01B1. And that can be determined before they start the therapy. So ideal would be the doctor, before they start the patient on a statin, would take that. They do that in chemotherapy already, so here's an opportunity to prevent it. So, indeed, their conclusion was that there was only a difference between overall difference 0.35 millimoles per liter. And I started looking into what is this millimoles per liter. This was done in England, and I looked up how you can convert that to what we use, the milligram per deciliter amount. So 38.67 times those numbers. So the number of deaths between the two doses was essentially the same from vascular causes and from non-vascular causes. I mean, it was identical in percentages. So why would anybody use the 80 milligram? So the advantages of the study I found were that it was the double-blind, multi-center, large sample size, long-term study, and they discerned that variant, genetic variant, that can be prevented in therapy, and discern that one can use 20 milligrams instead of 80 with essentially the same cholesterol lowering and a lower risk of myopathy. What I found to be the disadvantages is that they did say that they ran it through